Our next speaker, Dr. Russel Jaffe, graduated from Boston University in 1973 with an MD degree in internal medicine. He worked at NIH from 1973 to 1979. He's board certified in clinical pathology and also chemical pathology, and he is a researcher, a biological physician type researcher. He has a laboratory called Nutritional Immunology in Reston, Virginia, and he's prepared to give us some outstanding information that we can all use in our practices. Let's bring Dr. Jaffe up to our podium.
Could you unplug that? There we go. Let's try this. Now, try that. There we go.
One last thing. I just get some questions. There's some flyers of our courses up front for the American Academy of Neurotherapy.
Good morning. In the next several hours, we will review the major advances in immunology in the last 3 decades. We will look forward to advances that I think are on the horizon and available to those of you who are open-minded, objective, scientifically oriented, and willing to go by results, empiric outcome results. I believe that the future of biological dentistry and medicine is in the hands of those of you who are willing to be scientific and empiric, to go by results and to look at outcomes. We have, for the last 50 years, determined the results of what happens when you spend more and feel worse. We have the opportunity in the next several decades to determine what happens when you go by results and outcomes and define a new kind of health-based medicine in which you can spend less and feel better. In that, I'm paraphrasing from what was really a prophetic article written by Dr. John Knowles in 1977 in Daedalus magazine. And that prophetic comment was reiterated just recently by Dr. George Lundberg, the editor of the Journal of the American Medical Association, when he said last spring that our current medical care system will, within the next 3 to 4 years, achieve an operational and financial meltdown. That's the bad news. The good news is that those of us who have been thinking and working and tilling these fields have found outcome effective approaches that build upon an understanding of molecular biology and put that into practical terms in practices on a day-by-day basis, and it is that I'll focus on with you this morning, and in particular with regard to the immunotoxicity of toxic minerals. The immunotoxicity of toxic minerals may prove to be the bridging element, the common mode that allows our skeptical colleagues to understand that beyond the direct toxicity, at levels far below those which cause classic toxic effects, the kill 'em and count 'em effects of classical toxicology, far below those levels, there are immunotoxic hypersensitivity reactions which have been postulated to account for much of the adverse reaction from cerebral to other induced by toxic minerals. What we have lacked until now are available methodologies for documenting at the cellular level whether hypersensitivity exists, in which patient, and to which elements, so that we have a firm foundation on the basis of which to go ahead and perform appropriate detoxification or neutralization or other therapies. So I will be reviewing immunology in nutshell brief. I will be focusing on the immunotoxicity of heavy metals, how you can make that assessment in your practice and within the scope of your practice, and what to do about the results, looking at some of the outcome information that we've had. You should have in your syllabus material that Ed and Carol Arana put together. This would be on the left side, the fourth item, and it starts out by saying chelation therapy for acute and chronic metal toxicity, and I'll be following those notes over this time. This should be the fourth item on the left of the syllabus folio, and it should say chelation therapy for acute and chronic metal intoxication. Toxic metals, when they bioaccumulate, and particularly when they cause immunotoxic reactions, and I'll back up in a few minutes and ask whether they cause immunotoxic reactions, how we have decided that they do, and what one can do to assess them and do about them. But when toxic metals accumulate, they predispose to chronic illness, they enhance the consequences of chronic illness, and they increase the probability of treatment failures. And if we say this in a different way, the appropriate assessment of hypersensitivity and or toxicity to heavy metals, the appropriate diagnostic tools and therapeutic interventions then reduce the risk of chronic illness, reduce the consequences of chronic illness, and increase the probability of successful treatment outcomes, and particularly when applied to the treatment-resistant patient, the recurrent treatment failure patient. It opens up whole new avenues of outcome success. Now, what have we learned in the last 30 years from molecular immunology? We have learned that, first of all, the patient's immune system is patient-specific, that our immune repertoire is patient-specific. Each individual has their own accumulated hypersensitivity response pattern, and they are as distinctive as our faces and our fingerprints, and they have provided, I think, the basis for much confusion, because in the absence of a simple arthritis is caused by nightshades and asthma is caused by milk, or some linkage between the consequence, the symptom, and the cause, the underlying hypersensitivity, in the absence of that simple link, there has been difficulty in understanding what the link is between the repertoire of immune responses, the patient-specific hypersensitivity responses, and the outcome, the clinical outcome. Well, now we know that it is possible, not just under the conditions of the research laboratory, but in clinical practice, to determine what the hypersensitivity reactions are. But now the story gets more interesting and in some ways more complex, because there are 4 types of immune responses. One of them is immediate, and 3 of them are delayed. The immediate reactions are mediated by antibody E, IgE. The delayed reactions, when Gell and Coombs defined their nomenclature, they said there were humoral, there were immune complex, and there were direct cell mediated reactions. And within the humoral family, IgA, the mucosal antibodies, IgM, the immediate or acute reactive delayed hypersensitivity antibodies, and IgG, the immunologic memory, could all be involved. So when we're talking about immediate reactions, the modified RAST procedures, like the Fidel nail buff modified RAST, is appropriate for determining the type 1 or immediate reactions. But for the type 2 reactions, it would be helpful to know whether it is an IgA, M, or G reaction, an immune complex reaction, or a direct cell activation reaction. And there have been many assays developed. There have been IgA-specific assays developed. There have been IgG and IgG subtype assays developed. There have been immune complex assays developed. There have been direct cell hypersensitivity testing assays developed. When you start overlapping all of these in order to get a complete fingerprint of immune responses, you find that it's a lot of testing and a lot of money. When I first became interested in this field a decade or more ago, I asked the question, where could we make a contribution? Where could my intersection of being a tinkerer in the laboratory, one who develops new methodologies, intersect with a clinical question that could help establish the validity of biological medicine and biological dentistry? And the opportunity intersection that seemed most opportune was the immune system, because the immune reactions are at the cause of many chronic illnesses, the autoimmune illnesses, that now account for the largest amount of suffering in this country, the largest amount of treatment-resistant condition in this country, the largest amount of dollar expenditure in this country. We will spend this year close to $500 billion on the mitigation, on the symptom reduction of the host of autoimmune illnesses. And most of that therapy will be designed only to reduce the signs and symptoms of ill health, to suppress the symptoms, because we don't have effective therapies at the causal level to understand what is going on and what we might do to mitigate or minimize or reverse and neutralize those underlying causes. And it is meetings like this that I think are at the frontier of looking at what the causes are, not just the consequences, what the underlying mechanisms are, and so we have a whole new set of opportunity areas for diagnosis and for assessment. So it would be helpful to have an assay that lets the body speak for itself, to measure IgA, M, and G reactions, immune complex reactions, and direct cell reactions. And when I say lets the body speak for itself, the situation gets a little more interesting and complex, because at the antibody level, there are both good guy protective antibodies and bad guy reactive antibodies. So if you only measure quantitatively or qualitatively an antibody type, IgG or IgM or IgA, you will miss the important functionality that distinguishes the good guy antibody that protects the patient from the bad guy antibody that is reactive and blocks the recovery response. So something more than an antibody quantitation or qualitative procedure is necessary, and we have developed a lymphocyte response assay, an autologous lymphocyte reactivity assay. That means the patient's whole blood is in essence put in suspended animation and transported to the lab, where we get it to react as if it were in the patient. That is, we very carefully instruct you in how to obtain the specimen so that the coagulant system, the complement system, the kinin system do not activate. And our control procedures are first done to determine that the specimen is ex vivo. That is, the specimen will respond in the laboratory just as it would in the patient. And in that ex vivo assay, we can measure functionally the reaction of lymphocytes in the presence of all of the other cells that would normally be present in the flowing blood, the platelets and the mast cells and the monocytes and the granulocytes, The whole repertoire of cells is present in this mixed cell system so that we can see the functional response. We can, in essence, let the body speak for itself, but under the controlled conditions of the laboratory. And in that functional assay, you find that immunologic memory good guy antibodies do not trigger lymphocyte responses. Only the blocking or reactive antibodies trigger reactions. So this is a system that allows us to distinguish the immunologic memory. For example, if you had measles or mumps as a child, you should have IgG antibodies circulating in your body to protect you. Those are good guy antibodies. If we measured your IgG levels, for example, and found that you had antibodies to measles or mumps, it would not indicate hypersensitivity. It would indicate a helpful protective response. So it is helpful to go beyond antibody quantitation into a new generation of functional response assays. In Sweden, another approach is being taken to this same question, isolating lymphocytes, challenging them with toxic minerals, and looking at the production of cytokines or interleukins. This is a very exciting frontier that gives another functional response assay, in this case specific for direct cell hypersensitivity. That's what you measure when you isolate lymphocytes and you challenge them with a specific epitope or a specific item like mercury, and you look at the cytokine production. The autologous mixed cell culture, the ELISA-ACT system, is able to give you information about mucosal and IgM and IgG and immune complex and direct cell hypersensitivity reactions in one single sample and system. And it is that information that has allowed us to ask questions that start with, does immunotoxicity to minerals exist? And when we ask the question of does immunotoxicity to minerals exist, we want to go beyond that and ask if immunoreactivity exists. If that's been fuzzy for the last few minutes, it's not that you were up too late last night. It was out of focus. First question that we had to ask is, in this mixed cell system that allows the body to speak for itself, do we even find reactivity to heavy metals? So we started, as we always do, with a group of controls, a group of healthy people. We have a group of athletes. We have a group of people who work in our lab. We have a group of collaborators who, by a Cornell medical index, are essentially asymptomatic. It is very hard to find anybody in our culture who is truly asymptomatic, but if you have less than 5 symptoms on a Cornell medical index, we consider that to be a very low level of symptomatology, and we classify people on that basis as healthy. Also, if they follow the Bellick and Breslau 7 health habits, which is essential in addition to define them as healthy in this criteria. So the first question that we ask is, do healthy people respond? And the answer is, out of 22 people, it's hard to find healthy people. Out of 22 people that we've tested so far, none of them reacted. And if any of you are asymptomatic on a Cornell medical index, we would be delighted to obtain a specimen of you without charge to increase our base of healthier people so that we can enhance this population. But the first question that we have to ask about any assay system is, do healthy people react? Because if everybody reacts, or if a significant fraction of people react, then you're not able to distinguish the chronically ill population from the healthy population on a patient-by-patient basis, and that reduces the validity or reduces the importance and the predictive significance of the testing procedure. So then the next question is, do autoimmune illness people react? And here we have between 6% and 75%, depending on how you take that population apart, out of what is now in excess of 2,000 cell culture assays that we have done. And so we believe that there is more than coincidence, although the outcome results have to speak more importantly to this. We believe that there is predictive significance between the link of immunotoxicity to heavy metals in autoimmune disease patients and their clinical prognosis. and that, more importantly, if you apply a therapeutic regimen designed to press the reset button on the immune system, the immune defense and repair system, if you apply a therapy that is designed to press the reset button on the immune defense system, correct the nutritional deficits that have accumulated over time that have helped dispose to or amplify the symptomatology of the person, and teach certain healthy habits so that the person's healing response is evoked, that you have a therapeutic regimen of some value and some predictive significance. And we'll talk about that later in the talk. Now, I've said between 6 and 75%. That's a very wide range. How does that range get distinguished, and for which toxic minerals? And now we should turn to the material in the syllabus. And you'll find on page 6 an overview of toxic minerals. And we will talk about this for the next 20 minutes or so. And we'll get into, in the course of that, specific toxic minerals. And I'll give you some recent data from our laboratory on the prevalence of immunotoxic reactions, hypersensitivity, cellular functional reactions in different autoimmune populations. If you haven't seen it, I would commend to you the article that Riagu and Pekaina published in Nature, volume 333, page 134 in 1988. And they, as environmental toxicologists, asked the question of what is the relative importance, what is the relative significance of toxic mineral effects on the environment when compared with the long and growing litany list of other toxic effects on the environment. And they asked in an interesting way. They said, if we ask how much fresh water it would take to dilute various toxins to the ambient safe background level, how do the various categories of toxicants compare? And as they say, well, the annual total toxic load of all the metals mobilized exceeds the combined total toxicity of all the radioactive and all the organic wastes generated each year, measured in this way by the quantity of water needed to dilute to drinking water standards. Not that drinking water standards are necessarily such an arbiter of health anymore. George Leone, an acquaintance of mine who was on the water board in the Houston, Texas area, said that every 3 years for the last 15, the quality of water standard has been reduced so that the urban supply would pass potability. But I think it is of some interest and significance that as significant a problem as the radioactive wastes are, as significant a problem as the organic wastes are, the toxic minerals in our environment may even dwarf them in their significance. And of course, you see on a day-by-day basis what may be the important microcosm of that in the amalgam fillings in the susceptible or hospitable person. It does not seem to me that all people necessarily have a problem from amalgam fillings, and that may be something we would disagree with, but I don't believe that all people have a problem with toxic effects and hypersensitivities from the amalgam fillings. But I do believe that when you have both bioaccumulation of a significant pool of these toxic minerals, and when you have hypersensitivity, cell response, immunotoxicity complicating that, now you have an important risk factor. And identifying that, and identifying for which patient that is a problem, and then having an effective, low-risk, high-gain treatment program is an important opportunity area. And among other things, this differentiates your practices from the other dental practices in the area, and the outcome results, speaking for themselves, will draw many other patients to your practice. So, why would toxic minerals bioaccumulate? Toxic minerals bioaccumulate only when the host, the person, is hospitable. Why do people become hospitable? They become hospitable when their diet is too acid, and those acids reduce the body pool of other buffering essential minerals, whose job it is, when they're present in adequate healthy amounts, to prevent the assimilation of the toxic minerals. What are those nutritional minerals? Magnesium, zinc, manganese, molybdenum, and down to the trace minerals including chromium and vanadium and others. So the first predisposing risk to bioaccumulation of toxic minerals is the depletion of the essential nutritional minerals that protect the body and block the uptake of the toxic minerals. The toxic minerals are only assimilated in any significant amounts when magnesium and zinc and other essential minerals are reduced. And they are reduced by a diet that is acid-forming. The standard American diet is a very good example of an acid-forming diet. A high-protein, high-fat diet is an acid-forming diet. Protein yields organic acid residues as the end product of metabolism. Long-chain fatty acids yield oxidation products that are both acidic and free radical generating. A healthy diet is one in which 70 to 75% is complex carbohydrate, 12% is protein. That 12% will equal about 50 grams of protein a day. And the balance, which will be 13 to 18%, is dietary fat, hopefully whole foods dietary fat, unoxidized dietary fat, trans fatty acid, hydrogenated fat. And if you pay attention to the fat and protein intake, the rest will take care of itself. The average American consumes between 75 and 150 grams of protein a day, far more than necessary, and enough to provoke these acid residue products that themselves strip the body of the nutritional minerals and make us susceptible or hospitable to the toxic minerals. Question?
Do you consider fresh whole grains more on the acid side or more neutral?
Right, good question. And we have a chart, which I'll be happy to send anyone who's interested, on the metabolic effects of foods on body chemistry. Not the ash residue, but the actual metabolic effects of foods on body chemistry. And most of the grains are on the acid-forming side. So when someone says, gee, I'm switching to a healthier diet, and I'm going to eat a lot of grains, they may not be doing themselves a lot of good.
Do you make a distinction between bread versus oat groats that are freshly ground?
Well, you can make several distinctions. One between the whole grain and the processed, and another between the organic or biodynamically grown and the commercially grown, because the commercially grown will be more depleted in the minerals. The organic or biodynamically grown will be more enriched. So the organic or biodynamically grown are less acid-forming, and some of them actually alkaline-forming, whereas the commercial grains and grasses are almost all slightly acid or significantly acid-forming. And so the staple of the healthy diet is really fruits, vegetables, seeds, and some nuts, with the rest, including grains, as condiments. Thomas Jefferson said, "Let meat be a condiment in your diet, not a staple." And we could paraphrase that to say, even the grains, especially while you're recovering. And on the diet that I'm recommending is for people who are recovering from chronic illness. That diet is 80% alkaline-forming foods and 20% acid-forming foods. A maintenance diet might be 60% alkaline-forming foods and 40% acid-forming foods. But a therapeutic diet would be 80% alkaline-forming foods, 80% alkaline-forming, 20% acid-forming foods. Shouldn't be 100% alkaline-forming foods. You can get too alkaline, just like you can get too acid. You want to achieve a balance. But when a patient starts, as they often do, with a significant acid load, that has to be neutralized. You want to replace the minerals. You want to replace the buffering elements. You want to bring the cellular chemistry back into a healthier state. And that's why the recommendation of 80% alkaline-forming, 20% acid-forming foods. Question? Okay. Only when the diet and distress and immunologic reactions have provoked an acidic cellular chemistry. There's more than diet that provokes acidosis at the cellular level. Only when the diet and distress, the hormones of distress, interestingly, provoke acid residues in the body. And that's a subject for a whole day's seminar, but let me leave that as a challenge for the moment. We can come back to that in questions and answers because we have so much to cover. Only when a diet or distress or immunologic hypersensitivities, when the immune system gets activated, the complement cascade produces a host of acid residue. So when one or more of an acid diet, distress, and food chemical hypersensitivities is present, then the risk of cellular acidosis is high, and with cellular metabolic acidosis comes inefficient and reduced protein synthesis. That means repair will be reduced. The risk of increased permeability to the blood-brain barrier, increased permeability to the blood glandular barriers, increased permeability to the blood-gut barrier is heightened dramatically when the person has a cellular acid chemistry which reduces and makes inefficient the protein synthesis that should be repairing us. Many of the membrane receptors, the hormone endocrine membrane receptors, are exquisitely pH dependent. So when the cell becomes more acid, these hormone receptors get contorted and distorted, and they may bind inappropriately. They may make reverse thyroxine or reverse triiodothyronine, reverse T3, not T4, but reverse T3. That's a sign of metabolic acidosis-induced distortion of a hormone membrane receptor that provokes this aberrant form or reverse form of active thyroid hormone. There are many consequences, but let me rest by saying that cellular metabolic acidosis is an underlying disposition that you will find uniformly in treatment-resistant patients, in symptomatic autoimmune disease patients. In fact, it has been postulated that in the absence of cellular acidosis, in the absence of an underlying metabolic acidosis, a repair deficit, an immune a heightened state of reactivity, in the absence of that, autoimmune illness doesn't exist. That the necessary antecedents, the underlying necessary causes for autoimmune illness are cellular acidosis, hormones of distress, and hypersensitivity reactions, usually to digestive foods and chemicals, remnants in the digestive tract. Question?
When you talk about making reverse T3,
yes.
Do you mean the polarity like levo or dextro?
Right. I'm saying that when the body takes one iodine off of the dityrosine molecule that is thyroxine, it should do that in a stereospecific way to make active triiodothyronine T3. When the receptor gets contorted in acidosis, the stereoisomer iodine is removed, and now you get a competitor, not an activator. Okay? And Wilson syndrome has talked about this extensively. Broda Barnes implied this. It is clear in animals, and it is probably true in people, that some people with functional hypothyroidism or functionally low thyroid have that on the basis of a metabolic acidosis leading to production of competitive anti-T3. Bear in mind also, though, that all the symptoms of functional hypothyroidism, from being cold in the morning to being lethargic to having brittle hair to the GI distress and so forth, all of the symptoms of functional hypothyroidism can be induced by the neurohormone, the peptide neurohormone of distress, neurotensin. So if someone says, I'm cold in the morning and I'm lethargic and I don't have the endurance I used to, and my hair is brittle, and you go down the checklist and it seems like functional hypothyroidism, and they receive a therapeutic challenge of thyroid hormone, and they don't respond, you have made the presumptive diagnosis of a neurotensin excess. They have learned to release from their hypothalamus a hormone peptide that mimics low thyroid in every way. And of course, the treatment for that is to learn healthier adaptive coping mechanisms, not to give more thyroid hormone, because you can't overcome neurotensin excess with any amount of thyroid hormone. In fact, you can make people thyrotoxic, and you still won't raise their basal temperature. Okay. So, the underlying disposition to chronic illness is cellular acidosis, the consequences of distress, and hypersensitivity reactions in the immune system. And an area that has previously been underappreciated is the possibility that toxic minerals could account for some significant fraction of this immunotoxic load. And on the next page, 7, is an overview of mercury toxicity and hypersensitivity. I provide this mostly as a teaching tool for your staff, so you probably know this material and know it well already, but you may find this a helpful summary, the next 3 or 4 pages, a helpful summary for your staff or for your patients if they are suitable candidates for it. Question?
I just had another quick question. The neurotensin, you said that was made from the hypothalamus?
The neurotensin is made in the hypothalamus and released systemically. That's correct.
And so is there an easy blood test for that?
No. There is no easy blood test for neurotensin. It is done as a research procedure. The current cost of a research neurotensin test is over $1,000, and that makes it not an easy, in my book, not an easy or readily available assay. And that's why I said it's a clinical diagnosis at this point in time. As more physicians want to measure neurotensin, labs will be incentivized to develop easier and less expensive assays. There is, as yet, that I know of, no easy assay for neurotensin.
And so would there be any quick remedy for that? I mean, other than what you're talking about, like improve your diet, etc.?
Well, not just improve your diet. Where does neurotensin come from? Where does the hormone of distress come from? It comes from learned patterns of distress, patterns of helplessness and hopelessness. So what can you do for that? Abdominal breathing, traditional acupuncture, relaxation response training, neural therapy, active meditation. The behavioral component of what we will walk through as the ELISA Act program is based on relearning healthy habits and neutralizing the embedded patterns of distress that are manifest or shown hormonally and biochemically in the neurotensin excess. So yes, an alkaline diet is a helpful thing to do. Yes, avoiding and substituting for immunotoxins is a helpful thing to do. But when you also have neurotensin excess, I believe it's essential to learn healthy habits so that we reset the hypothalamic release mechanisms, which in turn are influenced by limbic and pineal gland precursors, and that response pattern is learned, it is not genetic, and can be relearned. And it is remarkable how just abdominal deep breathing, relaxation response training, salt and soda baths. Everybody familiar with salt and soda baths? Okay. Salt and soda baths means a half a cup each of baking soda and Epsom salts in a warm tub of water. And stay in that for 15, 20 minutes. People should come out pink like a baby, not red like a lobster. And baking soda and Epsom salts. So you have the alkalinizing effects of the bicarbonate and the soothing effects of the magnesium. The bicarbonate will open up the pores and allow organic acid residues to be released. The skin is an accessory organ of excretion. The magnesium can be taken up because those pores are bidirectional. If the body is depleted in magnesium, one very good way to get magnesium back in is through the salt and soda baths. Question?
Is Epsom salt better than sea salt?
Epsom salts is better than sea salt, but adding some sea salt with the Epsom salts is better yet. A balanced electrolyte solution is better than a magnesium-only electrolyte solution. The reason that I recommend the Epsom salts is if you're going to do one, the magnesium deficiency is so prevalent that that's the one you really want to go for. And magnesium is not present in large amounts in sea salt. Okay. But if someone says, what's the best, Doc? It's all three. It's baking soda, Epsom salts, and sea salt.
Russell?
Yes.
A point, there's a fellow named Jacques Delongre, he runs the Bread and Salt Society,
Right?
and they make a special kind of Celtic sea salt that actually is high in magnesium, and it's the way they harvest the salt from the sea. And you might want to look into that. In fact, we were going to use that as more or less like a bioplasma. We were talking to Jess, and he was going to show some of those, how this salt affects the cells.
That'd be great.
Various solutions.
While most sea salt that you get in the store is really very little different than table salt, when you evaporate seawater to completion, you have a higher magnesium content, but you're still talking about maybe 8 or 9 parts per million magnesium in the Celtic sea salts, in the Mar de Sel Mediterranean, fully evaporated sea salt, sea salt, sea salt. Whereas the Epsom salts will have the equivalent of 80 to 100 parts per million. So you do get a further enhancement of the magnesium. But if you want to use the best of the sea salts, I would recommend either Mar de Sel or the Celtic sea salts.
What have you found to be a good bath, detox bath for heavy metals?
What I have recommended is a half a cup of baking soda and a half a cup of Epsom salts. Although if someone says, what's the best? It would add to each of those a half a cup of Celtic or Mar de Sel sea salts.
Do you think that taking some Epsom salts internally?
No. No. We'll talk about oral detoxification programs, and I don't recommend mag citrate or mag sulfate as a purgative for a toxic metal detoxification program. There are other approaches that I do recommend for that. Question in the back.
Any difference in the baking soda that you decide to use as commercial or pharmaceutical?
Well, that's a good question. The baking soda that is sold by Arm & Hammer is the same baking soda that is resold as pharmaceutical baking soda, just higher cost.
What does the soda do?
The baking soda alkalinizes the bath, so that opens the pores and allows organic acid residues that have accumulated in the pores of the skin to be washed out and neutralized.
How often do you recommend it for the patients, ideally?
Right, how often? Daily. So we have numbers of people who during a therapeutic program, which may last 3 to 6 months, will take a salt and soda bath, and the first 5 minutes that they're in the salt and soda bath, they practice their deep breathing. The next 15 minutes, they practice their relaxation response or their visualization. And if you want to take it one step further, they may shine a dichromatic green light on themselves during this time to re-entrain limbic system responses. I emphasize dichromatic, not Christmas tree lights, but dichromatic lights. The filter that produces a pure green chroma has the effect of harmonizing the limbic system response through the anlaga of the Harderian gland in the eye, a non-visual but retinal neural pathway that goes into the limbic system and into the pineal gland, not into the visual cortex.
What gland is that again?
Harderian. Professor Harderian found in rodents this little light-sensitive, non-visual gland behind the eye, and it appears that in higher mammals, instead of a localized gland, there's a distribution of these photo but non-visual neurons throughout the retina. Enucleated patients lose this response. Blind patients have this response, for example.
What do you suggest people purchase as well?
The dichromatic lights are produced by GE and Sylvania. They are par 38 dichro, D-I-C-R-O, or dichromatic, D-I-C-H-R-O-M-A-T-I-C, par 38 dichro lights. Most lighting stores don't carry them. They have to order them from their distributor. So it's helpful for you to give them the whole designation, the par 38 dichro, 150 watt. Par 38, P-A-R 38, that's a lighting code that specifies dichromatic lights.
And you're looking at this through the eyes.
You are shining this generally on the face. It does not matter whether the eyes are open or closed.
Is this a bulb or?
This is a bulb. This is a 150 watt bulb, goes in a standard fixture. Right. Although if you're going to use it in the bathroom, you want to get a clamp that clamps on the towel rack. Make sure it doesn't fall in the water. I believe it is made in Sweden because Sylvania Osram is one of the manufacturers, and that's a Swedish company. Question. For how long? Well, it's an outcome results-based program. Typically, it's 3 to 6 months. A classic historical rule of thumb is that it takes 40 days of regular practice to change a habit, to re-entrain or re-ingrain a habit. So we're going a little beyond that because I'm not perfect. Few of the people I deal with are perfect. We don't do it exactly the same time each day, in the same place, in the same set, same situation. So typically it's a 3 to 6 month program, and it is outcome results oriented. We typically look at 1 or 2 or 3 laboratory parameters or symptom complexes, and when they remit and stay in sustained remission for 2 months, then we assume that the person has reestablished a new state of health and vitality.
How long do you suggest irradiation with a green light?
Oh, the same 20 minutes that you're in the bath. It's 20 minutes. Can be done twice a day. It's even better to do it, say, on a timer, first thing in the morning. This comes on as a way of waking you up. For people who are more night people than morning people, this can be a gentle and effective way of getting them up and alert. And then in the evening when they do their salt and soda bath, that's another time to do it. Question?
It's supposed to be excellent for releasing radiation that's been stored in the body.
That has been said, and it, I think, is another example that when we provide the basic tools, the basic resources, the body is quite effective and forgiving at cleaning house. And if I say that another way, when we accumulate these toxins, it's because something has gotten in the way of our normative repair mechanisms. That's one of the other exciting points of the immune system basic science in the last 3 decades, that our defense system is also our repair system. So if our immune system is under assault because neurotensin and cortisol, which go together, neurotensin and cortisol are high because of the stresses of high-tech living. The message of neurotensin and cortisol is, the other shoe might fall. Don't do anything. I'll get back to you. Cortisol is the body's natural immunosuppressive molecule. Why? When you're under assault, you don't want to overreact at a molecular level. When the tiger is about to pounce, you don't want to be so paralyzed with fright that you can't get out of the way. So you release cortisol, neurotensin, adrenaline. Now these are wonderful, alert, momentary molecules. When you live by cortisol, adrenaline, and neurotensin, then you set the stages for chronic autoimmune disease because you have enhanced your defense response at the cost of your repair mechanisms. And what we seek to do is take this imbalance, this excess of defense, this assault of immunotoxic materials, and reduce that. Excuse me. I try to critique the talks. What you want to do is identify and downregulate, decrease the hypersensitivity reactions by substituting for the immunotoxins, and we'll talk about how to do that, even down to the level of the toxic minerals, and press the reset button, press the adaptive coping skills mechanisms so that the hormones of distress are reduced. The cortisol, neurotensin, adrenaline are reduced. We learn these patterns. We often learn them very early. We may learn them so early that we didn't know we learned them. But if you want to know about abdominal breathing and how to do it, watch a baby. With the exception of crack cocaine babies, babies all spontaneously abdominally breathe. And the physiological as well as psychophysiological effects of just abdominal deep breathing are quite remarkable. So this is one approach to the challenge and the response to high-tech, high-toxic living that works concurrently at the chemical level, the alkaline diet, the immunologic level, substituting for identified immunotoxic foods and chemicals, and the endocrine hormonal level, pressing the reset button on the limbic hypothalamic responses.
I just wanted to get your opinion. A lot of people feel that it's more effective to strobe that light.
Some people recommend strobing it. If you know a great deal about their use, that can be helpful. However, bear in mind a few things. First of all, strobing at certain frequencies is provocative of seizures in seizure-prone individuals. So you have to be careful at what frequency you strobe. And discos provoked seizures in the 1960s and early 70s. And so disco owners have learned how to vary the strobe frequency so that there isn't one input signal that can overstimulate the predisposed nervous system. The next point, you're now adding another level of technology to the whole process. And is it worth that effort and cost? In my experience, if the only thing you're going to do is light therapy, phototherapy, then the strobe adds value to that. But if the light therapy is part of a total health enhancement program, an alkaline diet, an oligoantigenic, non-immunotoxic exposure diet, and healthy habits, we have not observed the strobe to add to that total program. Ed?
They talk about pulsing the electromagnetic radiation energy to give the cell a time to process it.
Right.
And it seems to be valid.
There's no question that at a cellular level it is. What I'm saying is I believe that you achieve a certain kind of pulsing by abdominal breathing. I believe you achieve a certain kind of pulsing by abdominal breathing. You achieve a certain kind of pulsing by an intentional and volitional relaxation response. So it's a question of how you want to do that. Also, light is quantized. Light is little packets of energy. It's not a continuous wave. It's not just a particle. It's really a wavicle. It's really quantized waveform energy. So there is actually a certain pulse to the green light as it's generated, and that is part of its effectiveness, the intrinsic pulsing of the green frequencies, which are about 600 nanometers or so. Okay, question?
Repeat what you said before the question started about the different levels that this therapy works on.
Right. This therapy works at the cellular chemical level. That's an alkaline diet. The therapy works at the immunologic defense and repair level by substituting for the immunotoxins with non-reactive foods and chemicals. And it works at the hormonal endocrine neurochemical level by cultivating healthy habits to press the reset button on the overall neuroimmunoendocrine control system of the body, because that's another insight and advance that we've made in the last 3 decades that we're beginning to integrate into practice. The immune system, the endocrine hormonal system, the neurochemical system are not isolated. They are different facets of one control system. And Oriental medicine appreciated this millennia ago. We have reconfirmed this in our molecular laboratories in the last few decades. So it's important for a therapy to have maximum benefit to address the different facets of the immunoendocrine neurochemical system, control system. Okay. Any other questions before we go on? Ed?
Are you going to republish your guidebook on
Yes.
metabolic nutrition?
Yes, thanks for...
Because we really missed not having it.
Well, thank you very much. If the more interest there is, the more I'm motivated to do the hard work to get that done. But thank you, because there's a lot of new material that we want to integrate into the next edition. But thanks for asking. Thanks for asking. Okay. Any other questions? Okay. So we were talking about one of the toxic minerals, and on page 11, we summarize, page 10 and 11, we summarize the amounts of mercury that people are commonly exposed to. This is old information to you folks, but new information to many, which is that having a large number of amalgams poses the highest bioburden of mercury on most people. Now, how do you distinguish who is at highest risk and who is at lower risk? The person who is on an acid-forming diet that strips minerals out of their body will then so avidly try to take up the limited magnesium and zinc in the diet that if there are toxic minerals present, it will take those along with it. And conversely, if there's enough buffering mineral in the body and in the diet, the body will exclude the toxic mineral and excrete it. And if the body is healthy and a little bit of mercury gets into the body, then it is deposited in an end tissue, nails, desquamating skin and hair, and excreted secondarily through that route. So only when we are depleted in magnesium, zinc, and other minerals do the toxic minerals like mercury and lead and nickel and cadmium and aluminum and arsenic bioaccumulate. Carl Pfeiffer used that to reason that replacement of zinc or zinc and other similar minerals could help people who were burdened with these toxic minerals. And his classic study that he did with Art Solar was in battery workers in Vermont. Just taking zinc and ascorbate was enough to displace the lead out of the battery workers over a 6-month period of time. And in an unpublished follow-up study, the battery workers who stayed with that program, they ate a better diet, but they took supplements that included zinc and other minerals. They took ascorbate. The battery workers who continue with that program did not reaccumulate the lead. The battery workers who went back to their old habits after the study was done did reaccumulate them because they got first into cellular acidosis. It took about 3 to 4 months for the cellular acidosis to reoccur, and then they began to bioaccumulate the lead again. So there's good laboratory, clinical, field, epidemiological data on the links between low buffering minerals and bioaccumulation of the toxic minerals and high nutritional minerals, high magnesium, zinc, and other minerals, and exclusion of the toxic minerals from the body. Yes?
Did you choose magnesium as an example because so many people are mag deficient?
Yes, I choose magnesium as an example because, yes, indeed, 80% of patients admitted to the coronary care unit are magnesium deficient at the cellular level, but only 20% show it in the serum tests.
That's
The
very
new
gross, isn't it, the serum test?
serum test is quite insensitive. The new ionized magnesium test that is just coming on the market and many clinical labs now offer is much more predictive of magnesium deficit, just like ionized calcium is better than total calcium. But beyond that, I picked magnesium because it is the prototype deficient mineral in our society. The acid diet draws more magnesium than anything else because magnesium is the buffering mineral of choice for the body. When the body can, it holds on to magnesium in the cells. Calcium is mostly extracellular, magnesium is mostly intracellular. So when the organic acids in the cells are produced in excess, then the body will give up some of its pool of magnesium so that the urine doesn't become so acid that it damages the kidney and the bladder. It's an adaptive coping mechanism. I'll tell you about one specific case with regard to the magnesium. A woman named Mary Lou Balwig is the head of the Endometriosis Foundation, Endometriosis is one of the many autoimmune diseases. She found out about the ELISAC program through her physician, who recommended this combination of low immunoreactivity diet, alkaline diet, and healthy habits, and her endometriosis went into remission, and she was a happy camper. However, she had been on steroids repeatedly to suppress the symptoms of her endometriosis. And by the time she was successfully in remission for her endometriosis, her bone density by double beam densitometry was less than 5% of her age-matched expected level. High risk. She followed this alkaline program for 1 more year. And she was tested, she followed the program for 22 months and then was retested 5 months ago, and she was at 85% of her expected bone density. So remineralization happens predictably when you correct the acidosis, correct the nutritional deficits, and reduce the distress.
What's the best way to get magnesium back into that cell?
The best way to get magnesium back into cells is to eat an alkaline diet.
What about IV?
You can give IV magnesium, but remember, if you've got the hormones of distress, if you've got the immunologic reactions, if you've got an acid-forming diet, you'll pour the magnesium in, and the body will pour the magnesium out. I have not found it possible to override the physiology. I'm recommending a physiologic program. If on top of that physiologic program you've got an acute situation, you may want to infuse a modified TPN that is rich in magnesium, potassium, and zinc, that is rich in ascorbate, that has essential amino acids including glutamine and cysteine and so forth, and we can talk at the breaks about anybody who wants to talk about those kinds of therapies. But the fundamental message I want to make is I don't think you can override the physiology even with the most enlightened of infusions. The infusions build upon good physiologic basis.
What if you have a physical problem, like a structural problem that's causing you distress as well as emotional? So how do you address that?
Well, let's say you've got a physical structural problem. Well, it's important that the structure be in alignment, and whether that be intelligent adjustment and chiropractic manipulations, whether that be Traeger-type rocking, neurochemical, structural alignment, whether it be Feldenkrais technique or a combination of those, that's a very important part of the program as we see it. But a companion important part to get the adjustments to hold is the alkaline diet, low immunoreactivity, healthy habits program. And we've worked with a number of colleagues who have patients come in, they're adjusted, they feel better, but the adjustments don't hold. Chiropractic adjustments, osteopathic adjustments, physical therapy adjustments, manipulative adjustments of a variety of sorts.
What about vertical problem?
Same.
So out of the supplementation, to the diet, in terms of the form of magnesium, what do you recommend?
The magnesium form that I recommend on top of the alkaline diet, it doesn't replace the alkaline diet, but the magnesium form that I recommend is called Mg+. That is a combination of 4 soluble salts. It's the magnesium ascorbate, magnesium aspartate, magnesium citrate, magnesium glycinate. And why those 4? The ascorbate for the electron donor electrochemical effects, the aspartate for the neurochemical benefits, the citrate for the energetic Krebs cycle effects, the glycinate for detoxification. However, some patients are so depleted in magnesium that they cannot uptake magnesium even in a completely soluble balanced salt form like this. And so along with the magnesium plus, I recommend choline citrate. And what you take is a 500 milligram magnesium plus capsule plus 1 teaspoon of choline citrate in juice. It can be in vegetable juice or vegetable broth or in fruit juice. The choline citrate is the chaser for the magnesium, and the choline citrate helps carry the magnesium into the body, bypassing the often inhibited magnesium-dependent ATPase pump. You need a certain amount of magnesium to take up magnesium. So if you're very depleted in magnesium, you can put the magnesium in the gut. It won't get assimilated in the body. So this magnesium plus and choline citrate which are available from Seraphim, like the Angels. Their number is 800-525-7372. They'd be happy to provide that with you and compare that with any other magnesium that you've used and see the combination. I think you will find, as we have, that it substantially improves upon all of the other good products, and there are many good products out there.
Did you find salivary pH is a good monitor?
Salivary pH is a very tricky monitor because in patients who are reactive, just putting a strip in their mouth can provoke an acid reaction or a catabolic alkaline tide. So in a stable patient, a healthy, stable patient, salivary pH is quite useful. I recommend urinary first morning pH. That's the closest inexpensive way of determining metabolic acidosis, cellular acidosis. And that is done by checking the first morning pH by the patient at home. And they can get, for urinary pH, the patient can get from their drugstore Hydrion pH paper. Best to get the narrow range between 6 and 8. First AM ought to be between 6.5 and 7.5. If it is below 6.5 or above 7.5, the patient is either in metabolic acidosis, that is if it's below, or in a catabolic alkaline tide where they're tearing down their muscle and structure and organs if it's too alkaline, first thing in the morning. Now, this is after a period of equilibration. During the day, the salivary pH and...
I'm sorry, the overhead. Could you raise the overhead?
Oh, thank you. Thank you. During the day, the salivary and urinary pH flux quite a lot, so you really need to know the metabolic balance of the patient to use that in a predictive way. After a period of equilibration, like after a night's sleep, the first morning urinary pH is quite predictive or reflective of the state of metabolic balance of the patient. And if you want to, you could have the patient use the wider range. There is the 0 to 12 pH paper, and they can then tell, well, I was 5.5 the day before, and I was 5.0 today, and I'm 6.8 tomorrow, or whatever. And you'll have people come in and say, gee, it's amazing, Doc, the mornings that I'm within my healthy range, I have a good day. And when I wake up in the morning and I'm too acid, that predicts an at-risk day. I hang a sign outside my door saying, grumpy situs today, or don't beat up on me today, or whatever.
Do you have any other source of the pH paper, pharmacy?
If the pharmacy doesn't carry it, there are a number of very helpful pharmacies that will send to you. Apothecure in Dallas, Texas, Gary Osborne, is one such source. He can also help you with the Perk products. And Apothecure's number is 800 969 6601. So if you prefer to get this through a specialty compounding pharmacy, Apothecure is a very good resource, and their number is 800-969-6601. That's for the pH paper, also for the Mg plus and choline citrate if you want, or you can get that directly from Seraphim depending on how actively you would use it. Question?
I know you haven't gotten very far yet, but
That's
you're
okay.
not stressing exercise?
No, we haven't gotten to exercise yet, and I'll tell you where that fits in, but the headline about exercise is that while the distress and the neurohormones and cortisol are high, while the immunoreactions are pushing cortisol and neurotensin even higher, exercise, vigorous exercise, may be contraindicated. Why? Exercise raises adrenaline and cortisol and so forth. When's the time to do vigorous exercise? When you're in balance. When you're in balance. We recommend that people start with either very gentle water exercises or trampoline rhythmic exercises for lots of reasons, and only after 3 to 6 months of a therapeutic program do they then get into more vigorous exercise. We've seen too many unhealthy athletes. There was a question over here that I may have missed. Oh, right here.
If you wake up in the morning and you're in acidosis, is there an emergency remedy you can down?
Well, yes, more ascorbate, more vegetable juice and vegetable broth, more of your buffering nutrients. So if the patient is acidotic, I would recommend a basic multivitamin, multimineral that is highly active like Perk 2 and an amino acid lipotropic to help rebuild the membranes like Perk 1. And when you're more acid, you might need to take 2 of those with each meal. When you're in a healthy range, 2 tablets a day of each is plenty. I would be sure and have 8 to 12 ounces of vegetable juice, freshly prepared, preferably from organic or biodynamic sources, on the days when I'm more acid. It's elective when you're in balance. In addition, if you're concerned about bone remineralization, you might want to add something like the Perk Bone Guard, which will add to the regimen containing boron and other bone-specific minerals that will help with the mineralization. And last, and far from least, ascorbate as the electron donor detoxifier of choice. How much ascorbate? As much as you need, and it may be more than many people would think, so that my preferred way of determining the ascorbate is either through the use of ascorbate determination either through the C flush, which the folks at Seraphim would be happy to send you, 800-525-7372, or C strips.
You can put it down a little bit there.
Thank you. The C flush is done by the patient taking enough buffered ascorbate that they achieve a flush as if they had given themselves a watery diarrhea. And I emphasize the flush. The one caution I have here is don't stop when the stool begins to loosen. When you've started to pull the toxic matter out, don't stop. Go through to the watery diarrhea flush. And most people will feel substantially better after the flush. If people stop in the middle, they may call you up, or they may call me up, or you may call me up and say, well, I got cramps, or I got gas, or I got a queasy feeling in my intestines or something. When that happens, ask the patient whether it was water coming out like they had given themselves an enema. That's the flush. Now, how do you get to that? Well, sometimes it takes a little, sometimes it takes a lot. Healthy people, my flush dose for ascorbate is now 4 or 5 grams. When I first started, my flush dose was higher. I was giving a talk once and a woman said, Doctor, was there something wrong with me? It took 300 grams to achieve a flush. I didn't know what to say, so I said, tell me a little about yourself. She said, well, for 20 years I had been constipated. I'd had crippling ankylosing spondylitis. I had some strange variant of multiple sclerosis. I was a wreck. I heard about your C flush, and I heard that it was important to push through to the flush. It took 300 grams to achieve the flush. And 3/4 of the amount to achieve the flush is what we recommend on a daily basis. So she took about 225 grams a day for a period of time. And she found, as many people will, that in the active repair phase, the amount of C to achieve the flush goes up initially a little bit. It goes up because the body is more active in repair, in connective tissue synthesis, in cleaning house, in detoxification. The flush dose may go up over the first few weeks, and I recommend doing this on a weekly basis. The flush dose may go up for the first few weeks. Then it will plateau, and then it will come down, and come down dramatically. The woman I'm talking about achieved her flushes in the healthier state that she was in when she came to the lecture at 12 grams of ascorbate. So she started at 300 grams, she went up to close to 350 grams, and then as she got healthier, the amount of C reduced dramatically, and she was, at that point in time, achieving a flush at 12 grams. Question?
Even though that's buffered that much vitamin C, wouldn't that cause acidosis?
Well, no. The fully buffered ascorbate, like the Perc C, is completely buffered with calcium, magnesium, zinc, and potassium in a balanced salt form. So we recommend that. Although above 50 or 100 grams, you can add ascorbic acid, because if you're doing the other things that we're talking about, you'll have buffering minerals coming in from other sources. So you can stay with the buffered ascorbate all the way, or you can start mixing ascorbic acid in without losing buffering potential over 50 or 100 grams. There are not a lot of people who will need 100 or 200 grams of ascorbate to achieve a flush. Right. Ed?
How would you compare the C flush with the IVC drip 750 milligrams per kilogram body weight?
Right.
The old flash oxidation.
Right. How do we compare this with IV ascorbate? If you give 750 milligrams per kilogram, which for a 70 kilogram person is 50 to 60 grams of ascorbate, you will resaturate, or hopefully resaturate, the tissue cellular ascorbate pools. And I recommend doing a peak and trough ascorbate level to determine how much the person needs, because some people need less. Some people will hit the therapeutic target at 25 grams, and other people need more. A fellow came to see me. He was HIV positive, but he was robustly healthy, or to appearances robustly healthy. His Chinese pulses weren't so healthy, but appeared healthy. We put him on infusions, which were 50 grams twice a day, as a virucidal action following Jarawala and Pauling's work. And he came back, and his peak level was 5 milligrams per deciliter, and his trough level was undetectable. That was subtherapeutic. The peak level for IV as a virucidal ascorbate, you want your peak level to be 50 to 80 milligrams per deciliter. You want your trough or pre-infusion level to be 10 to 20 milligrams per deciliter. So I thought it was a lab error. So we repeated the study, and it came back equally low. And then I realized that I was looking at the surfaces, not at the underlying situation. We went to 100 grams twice a day. He barely budged his peak and trough ascorbate levels. We went to 150 grams twice a day, 300 grams a day IV. Then he hit his therapeutic peak and trough targets. He never had a flush from the IV ascorbate, and that's part of the moral of that story. The IV ascorbate bypasses the gut. You need to take oral ascorbate along with the IV to bathe both sides of the gut wall.
Would you consider doing both at the same time?
Oh, absolutely. I had this fellow, while he was on infusion, 150 grams twice a day to achieve peak and trough therapeutic levels. He was also doing an oral ascorbate flush once a week. Now, at those IV levels, it didn't take him a lot to achieve his oral flush. So at 20 or 25 grams, he achieved an oral flush. But interestingly, when he was not infusing, he went traveling and broke his infusion protocol for a period of time. When he was not infusing, he never reached an ascorbate flush. He stopped at 150 grams and said, I can't take all this ascorbate. So there is a relationship between IV and oral. That is, the IV diminishes, the IV saturates the tissues. The target is to saturate the tissues, so you will saturate the gut at a lower level. But importantly, the ascorbate given by vein does not get into the mucosal tissue very well. It's not a well vascularized tissue. So you need some oral ascorbate to go along with the IV. Question?
Russell, when you refer to those levels, you take blood and send it into the lab?
Yes, this is plasma levels. This is plasma blood levels sent to a lab that does a good plasma ascorbate.
And at what time in relationship to the IV do you take those?
Right. These plasma levels are determined, the peak level is determined at the end of the infusion, but from the other arm. Because if you're infusing in this arm, you must take the blood from another site because you'll get a very high ascorbate level. In fact, a woman here in this community had blood taken from the same arm that the IV was infusing in. She had very high ascorbate levels. Okay? Now and when that happens, that's an artifact. That's not a tissue measure. So it must be taken from another site, but just after the infusion gives you your peak level, just before an infusion gives you your trough level. Okay?
When you start this flush program,
Right.
how do you start doing it?
Right, how do you start? You have to make a clinical assessment whether this person needs a little, a bunch, or a lot. If they need a little, it can be 2 grams or half a teaspoon every 15 minutes. If they don't achieve a flush over the day that they do that, then they should restart at 4 grams every 15 minutes. And there are people who, even taking 4 grams every 15 minutes, which is 16 grams an hour, in 10 hours through the day, will not achieve a flush. And for those people, you then go to 8 grams or 2 teaspoons every 15 minutes. And the way to do that is to make up a jogger's bottle. So you know how much ascorbate you're adding to a known volume of fluid, and you take a couple of ounces of that every 15 minutes. You don't have to mix up all this stuff every 15 minutes. But I promise you that at 8 grams every 15 minutes, they will achieve a flush. And if they don't, call me. We'll have a new record setter.
On that same day, they achieve.
On that same day, right. 8 grams every 15 minutes, which is 32 grams an hour. If you do that throughout a day, you'll go over 300 grams for the day. Okay. Question?
What about the fat-soluble ascorbate?
What about the ascorbyl palmitate, the fat-soluble ascorbate? Can be helpful, but what I recommend is a balanced supplement program. If you say to me, I only want to give one supplement, then I would recommend giving both the buffered ascorbate and the ascorbyl palmitate. But if you're going to give a balanced supplement program, then you'll get other fat-soluble antioxidants, the beta-carotenes, the tocopherol selenium, and others. And it's the family of antioxidants that you really want to get in, from E and selenium to ascorbate, to glutathione precursors, to riboflavin, to coenzyme Q10, to histidine and others. It's the family of antioxidants that plays the symphony of life. It is not one instrument, however elegantly played, that plays the whole tune or plays the whole symphony. Question?
Have you ever heard of anybody taking antioxidants and then all of a sudden breaking out with herpes?
Someone takes antioxidants and breaks out with herpes. They were taking oxidized antioxidants. The antioxidants are just that. They are free radical trappers and they are life enhancers, if you will. But a lot of the antioxidants can be oxidized. Ascorbate, sometimes through poor manufacturing and storage, actually oxidizes to diketogulonic acid, the double-step oxidation. That's a pro-oxidant. That causes scurvy. That isn't a treatment for scurvy. Much of the vitamin E that people take is in soybean oil, and that soybean oil is full of biocides. It is full of oxidation products. It may be full of hexane, and people may have a hypersensitivity reaction to the soybean oil or to a contaminant in the soybean oil, and that will generate free radicals on top of any oxidation that has happened to the unsaturated fatty acids. So if someone gets cold sores or an outbreak of herpes when they're on antioxidants, the probability is they're having an immunotoxic reaction to the antioxidant supplements, and or the antioxidants are oxidized themselves. Go with a brand that will certify that they are absolutely antioxidant specified. That is, their bioavailability at the cellular level, is known, and that precautions are taken at each step to protect the delicate antioxidants from oxidation. Question?
What would happen if somebody used a non-buffered ascorbate? How would that differ with the result?
Right. Now, if you don't use the buffered ascorbate, you can get high enough ascorbic acid intake to irritate the stomach, to start mobilizing the dentin off the teeth, and to provoke a further acidosis in an already acidotic person. So under no circumstances do I recommend that the C flush be done with ascorbic acid. Always be done with the buffered ascorbate. And you choose the buffered ascorbate of your preference. Question?
2 questions. First, how often do you recommend giving the C flush? And secondly, where can we get these PERC 1, 2, and PERC C products?
Right. The PERC products are available from Seraphim at 800-525-7372. They can send you the C flush as a courtesy. They can sell you the C strips. I think it's 100 strips for $10 or something like that.
What's the
And
difference between C flush and C strip?
right, the C flush is an instruction of how to take oral ascorbate until you get a watery diarrhea-like flush. The C strips is a dip strip. You dip the strip in fresh urine, or you pee directly on the strip. And you use that to determine how much ascorbate you have in the body. And people can do that every time they urinate if they want. And they will find, Dr. Lisa Reamer and others are doing studies with us, and you find that some people's need for ascorbate varies within the day. So they may be okay in the morning, but because of work stress or other environmental pollutants, by the afternoon they may need a much higher ascorbate intake to buffer them and to cover them for antioxidant protection. So the strips are something that can be done each time the person pees. The flush will determine the amount that will cover them throughout their day. Some people prefer one, some the other. You choose patient by patient. Okay? Steve?
For the IV vitamin C,
Yes.
do you use distilled water as a carrier or
Well,
Ringer's?
right. What do you use for the carrier for the infusions? You can make a good case for lactated ringers. And you can make a good case for sterile for infusion water if you've got an absolutely reliable person. You never want to infuse sterile water, of course. But if you put 50 grams of buffered sodium ascorbate, buffered to pH 7, in sterile water, you'll have an isotonic, isosmotic liter of infusion fluid. If you put it in 500 milliliters, you have a hypertonic solution, but well below the tonicity of hyperalimentation, very safe to do. Some have argued, and I think with some interesting data, that lactated ringers facilitates the uptake of the ascorbate into the cell, and the lactate itself is converted to pyruvate, carried in through acetyl-CoA into the Krebs cycle, so that's another way to jumpstart the energetic cycle in the body. I've seen data on both sides. I think you can sensibly use sterile for infusion water and add ascorbate and electrolytes. You can sensibly use lactated ringers and add ascorbate and vitamins to that. I think at this point a matter of choice.
Do you use McGuff or you use the same company that you suggested here?
Apothecure is a good source. McGuff is fine. But these are standard materials. They're available from Abbott and from all of the major infusion companies. The ascorbate is actually made by Merit Pharmaceuticals and repackaged by everybody else. So if you want to get the ascorbate at least expense from the primary manufacturer, it's Merit Pharmaceuticals. And interestingly, Merit Pharmaceuticals got into this because the Department of Defense called them up and said, could we have 50 million vials of 25 grams per vial ascorbate, please? And the guy said, you want to say that again? The Department of Defense has a stockpile for biological warfare risks, for other high-risk situations. And once they got the technology down that way, they can make it very inexpensively, and they do repackage it for lots of other sources, and it's fine. It's the same material. If you're interested, Merit Pharmaceuticals can be reached through... yeah, here we are. 800 421 9657. This is for IV ascorbate, and they make, among other things, a 25-gram single use, which means preservative-free, vial.
What city are they in?
They're in the LA area.
Is that the same product that they just call vitamin C?
Yes, they call it vitamin C for infusion, and on the side it says preservative-free, buffered, and it's really sodium ascorbate, but they say it's vitamin C for infusion. That's the USP label. That's the USP label. But look at the side and make sure it says buffered, as it should, to pH 7 and preservative-free.
Just out of curiosity, what happened to the person, the HIV positive person that you did all this to?
Turned HIV negative. Thanks for asking.
This last question, patient with kidney failures, do we have to be very careful with this? Is this sort of
Oh, yes. Now, what about special circumstances? And thanks for asking. If the patient has renal failure, then you want to work with a metabolic expert who can help you determine what fluid and what electrolyte balance the person needs. Now, what do I mean by renal failure? I mean a creatinine over 10, a creatinine clearance below 10 mils per minute. If the patient has a creatinine of 3 or 4, that's impaired renal function, but you can often reverse that with this kind of alkaline diet repair mechanism, and I recommend that you do that, and you don't need special precautions. But if you've got someone who is being dialyzed or on the edge of dialysis, work with a metabolic expert or yourself get immersed in and take some seminars in the metabolic balancing. And I'll tell you a brief story. A previous Secretary of the Treasury, Doug Dillon's father, C. Douglas Dillon, developed kidney failure, complete kidney failure, at the age of 60. He was never dialyzed. He died healthy at 93. Every day, intensive saunas and metabolic balance studies were done on him so that the skin was used as an accessory kidney, as an accessory organ of excretion. So these approaches can work. That is a very labor-intensive approach. You have to put the person in the sauna and you measure the specific gravity of their sweat and saliva, and then you wrap them in towels and do herbal wraps and so forth. This is not an easy thing to do, and I'm not implying that it is, but it can be done. What?
What was the titer you were looking for from the sweat?
We wanted to basically get the concentrated solute out. So you want the specific gravity of the sweat to approximate concentrated urine at the start, so it was over 1.025. And he was in healthy balance when it went down to less than 1.015, indicating that his waste products had been mobilized out and his sweat was now returning to a healthier level.
Is it possible to send patients like that to you? Are you set up to see people?
Right. I only do research. There are physicians, clinical physicians around the country who follow these approaches. I'll be happy to work with you on any complex cases, but we absolutely happy to do it. Those are the fun cases, the challenging cases. We all learn from those cases because very often they teach us something new. But we have only a laboratory. We don't have a clinic to go with the laboratory, not yet.
What is your number?
Number is 800 553 5472. SPL is the lab that brings you the ELISA ACT test, and that is the immunotoxicity test that we'll talk about in wrap-up for the heavy metals.
One comment, Russell. If you're going to use a lot of vitamin C,
Right.
I think it's more safe to use it as sterile water, because otherwise, if you're using your ringer, you're going to have too high osmolarity in the solution, and will cause probably sclerosed veins and things like that. So it's better to use, if you're planning to do high doses, let's say more than 50 grams or more at this HIV patient needed, it's better to use sterile water.
Well, let's build on that for just a minute. If you're going to have the patient on a therapeutic ascorbate infusion program, I believe you want to have a continuous therapeutic level of ascorbate. If you were going to use an antibiotic, you would want a continuous therapeutic level of that antibiotic. Well, by analogy, if you're going to use the ascorbate as an antiviral therapy for hepatitis or for other viruses or for other reasons, I believe it's best to maintain a continuous infusion level of therapeutic amounts. Now, that means typically a twice-a-day infusion that goes over 2 hours, can be done on portable pumps at home. Home care companies are getting familiar with this and can help. But if you're going over 25 grams of ascorbate, you need a central line. Now, you can have a percutaneous central line, a line that a nurse or you place through the antecubital fossa, threading up into the superior vena cava, because the osmolarity of the solution will be high enough that a peripheral vein will not withstand the twice-a-day daily infusion for the weeks to months that is needed. Now, if you're going to do this in an office setting and you feel the patient needs a boost, they need the ascorbate once a week, then I would recommend the sterile water, and you can do that through a peripheral line if it's done slowly over an hour or two. Okay? When I was saying lactated ringers, I was thinking in terms of a maintenance of continuous therapeutic ascorbate levels, and that's best done by home infusion. Patients can manage that fairly easily, typically from 8 to 10 p.m. they'll do an infusion, and then from 5 to 7 a.m. on a clock, the pump comes on and they do the infusion. Question?
Sir, do you ever routinely order a GP's glucose phosphate test on patients before you deliver high-dose vitamin C to them?
We have, in years gone by, measured G6PD and oxalate in the urine and B12, but we have also done now at least 24 G6PD deficient people. And as long as you don't cause osmotic shock, there's not a problem. So G6PD deficiency is really a red herring about ascorbate. And by that I mean any G6PD deficient patient, any patient, should not have an acute osmotic shock load poured into them. And G6PD deficient people are more susceptible than the average to that, but so is anybody. But it's an osmotic load problem, not an enzyme-specific problem. We had Clintek, an infusion study company, look at the stability of ascorbate, B12, and lipid when stored together for 28 days under conditions that would accelerate their interaction and deterioration. There was no degradation of B12. There was no oxidation of ascorbate. There was no dispersion of the lipid micelles. So the issue about B12, in physiological terms, ascorbate does not destroy B12. There are some assays in which large amounts of ascorbate in the test tube prevent the assay from turning positive. Just like the occult blood assay, the hemoccult type assays are inhibited by ascorbate. That is an artifact in the test tube. That is not a toxic physiologic effect. And one last point about the ascorbate, it has been said that patients who have large amounts of iron may have shock-like reactions due to the mobilization of the iron. We have certainly not observed it. None of the infusion centers that I know of around the world who have used ascorbate have observed that. It has been raised as a theoretical possibility because of one patient, and I believe it was in 1952, who had an ascorbate infusion, may have been an osmotic shock problem, and did go into shock and died. But there's not much known about that case, and a great deal has been made about what is little known about that case. So my recommendation is that you can use the ascorbate for infusion with comfort and with impunity as long as you follow sensible rules. Don't put hypertonic fluids quickly into peripheral veins. And just, good infusion etiquette, and you'll be okay.
You run across anyone who has the sensitivity to vitamin C?
We have run across people who have had hypersensitivity reactions to the corn-based ascorbates. However, Merit Pharmaceuticals has now switched away from a corn-based ascorbate. The PERC buffered ascorbate is a non-corn-based ascorbate, just for that unusual but occurring problem of the corn hypersensitive person being sensitive to the residues of corn in most of the commercial ascorbates, which are not very pure. The PERC buffered ascorbate is recrystallized 3 times. Why is that done? So that you can sleep at night with more comfort that you're giving your patient a purer product. And so that the buffering is fully dispersed throughout the material as well. Question?
You mentioned a moment ago the possibility of dentin dissolution.
From ascorbic acid.
Yeah.
Right.
I've seen patients in my practice who deny being anorexic.
Right.
And those kinds of problems, yet obvious dissolution of the tooth surfaces.
Right. You can
Might
have.
there be an explanation in there being hyperacidic systemically?
That's right. If you are systemically acidic, just from diet and distress or food chemical hypersensitivities, the acidity will reflect itself in your saliva as well as in other fluids of the body. And that acidity can ionize the calcium on the surface of the dentin and cause some mottling and some erosion of the dentin surface. So it's not only ascorbic acid that can cause that. If the saliva itself is too acid, that can cause it.
Now, this particular patient is she looks anorexic. She's very, very thin.
Right.
I would refer her to a physician then who could evaluate the pH situation.
Right. You could, let's say that a patient like this walks into any of our offices. The patient looks as if they have an eating disorder or might. They are very skinny. You talk to them about it and they say no. Well, denial is a common first stage or second stage component of eating disorders. So what can you do? Well, one thing you can do is manage them yourself with an alkaline diet and targeted supplementation and healthy habits. But if they're resistant, they just can't get those salt and soda baths done. They just can't get the supplements in. They just can't avoid the foods to which they're immunotoxic. Then I would recommend referring them to a multi-specialty center that has a sensitivity to all of these issues. And it's hard for any one individual to keep all of this in their therapeutic repertoire. Are you out here?
I'm in Carson City in the back, near Reno.
Near Reno? Dr. Tom Sult, S-U-L-T, in Reno, could help you with these kinds of cases.
S-U-L-T?
Right. In Los Angeles, Dr. Richard Lander, L-A-N-D-E-R. And see me afterwards. I'll be happy to give you a phone number for Richard. And there are several other very fine physicians in the LA area that could help with this. Okay. Any other questions? Question?
What brands would you recommend?
What brands?
For multi-supplementation?
I recommend any brand that can tell you the bioavailability of the material, which is another way of saying the purity and assimilation of the supplements, the bioavailability of the supplements, that the supplements are protected during formulation and manufacture and storage so that what was on the label is actually available to the patient.
I was hoping to benefit from your research.
Well, the PERC products are an example. These PERC products are an example that fulfills that. But I think that any product that satisfies the bioavailability, purity, and full disclosure labels, that is, the supplement company will tell you everything that's in there, whether it's inert, whether it's not inert. And the better companies today can manufacture products that are free of binders, fillers, excipients, and other agents. And I recommend that. Question?
Dilute lemon water will alkalize the system. Do you use that in your protocol?
If the person is not immunotoxic to citrus fruits, the citrus juices you will find on the chart indeed are alkalinizing because of their citrate content, and that's a sensible, healthy thing to do. But you want to know, of all the sensible, healthy things to do, which are immunotoxic for that person. And either as a screening test for toxic mineral hypersensitivity, this functional lymphocyte assay called ELISA ACT is available as a toxic mineral panel that tests for lead, mercury, cadmium, nickel, aluminum, and arsenic, and that costs $125. It is also part of a larger nutritional, there is also separately a nutritional panel which tests 235 foods, preservatives, medications, and environmental chemicals, and that with interpretation, including a treatment plan of how to substitute, what supplements to take, and what habits to change, is $535. And then there is a complete ELISA ACT, which is 300 items, including the toxic minerals and a whole lot more. That 300-item test costs $695. In some cases, insurance reimbursement with pre-authorization allows for assignment by the lab. Our lab will work out payment plans with patients to spread this if the cost is an issue. If you reduce your fees for a patient, we will reduce the cost correspondingly. But these are ways of either as a screening test, the toxic minerals alone, and when the patient sees a hard copy piece of data that they are hypersensitive to one or more of the toxic minerals, you will probably have a much more motivated, much more compliant patient for any of the therapies that you'll be doing. Thanks. And if you think the case warrants it, you may want to look beyond the screening toxic mineral test for a nutritional panel that tests the 235 foods, environmental chemicals, medications, and preservatives, or the complete study, which tests all 300 for $695. Now, there may be some sticker shock when you say to the patient, this test costs $695, or when you add your interpretive fee, because you will have to go over the results with the patient, and that adds value and should add cost to the procedure. But when the patient understands that 300 different cellular assays are done by 3 different techniques, a total of over 900 ways of profiling their immune system, that it's like an MRI. It's like a CAT scan in the detail of information that you get, but in this case about the immune system, and that this uniquely can profile the functional responses of their immune defense and repair system, and most importantly, has a therapeutic outcome. The information goes beyond how to identify the toxic substances. It goes beyond that to recommend what to substitute, what to supplement, and what habits to evoke based on a questionnaire and the culture of the cells when you request it. That treatment plan has been extremely helpful in carrying the information into practice, and we are grateful for the opportunity to be of service as we can on those assays.
Russell, in the toxic mineral panel,
Yes.
does it measure the toxic minerals in the red cells and white cells, or in the serum?
This is a whole blood assay, so we are looking at lymphocyte recognition, either from humoral antibodies, any of the 3, or immune complexes, or direct cell activation. So however the patient has a hypersensitivity to the toxic minerals, we will pick it up in this functional cell culture.
So you conclude from the allergic reaction that the patient has to the toxic minerals that in fact he has toxic minerals? Is that?
No, there's no simple relationship between burden and immunotoxicity. Let's say, for example, the patient has been following your advice for a period of time, and the body burden, the mass of toxic mineral, is now reduced and very low. They could still have an immunotoxicity to the small vestigial remnants that remain. And until you identify and appropriately neutralize those immunotoxicities, the patient is still at risk. This morning, someone said they got 75% better or so and plateaued. That might have been a sign of immunotoxicity, and the other therapies that you applied may have pressed the reset button on the defense and repair system. So it is not an amount, but rather a hypersensitivity or a delayed allergic reaction that we're looking at.
Yeah. The real question is it possible to have this test be low and still have a high body burden?
The other can also happen, and I recommend provocative urine mineral testing for burden, and I recommend ELISA ACT for hypersensitivity. And there are people who have got a boatload of toxic mineral, but they're not hypersensitive.
Is there a number that you have? Is it correlating most of the time or some of the time?
Oh, if you look at the regression coefficient between burden and hypersensitivity is 0.875, which is a high regression coefficient. However, we've seen people over and again who have got a boatload on provocation, and they're not hypersensitive. We've seen people who are hypersensitive, and significantly so, who don't any longer have a burden in their body. So on a patient case basis, there's no simple relationship. There is an important statistical relationship, and that's part of the database. Right, thanks. Question?
Could you use hair analysis for the toxic minerals to give you kind of an estimate of the burden?
If you want,
to see the sensitivity?
Can you use hair analysis? If you want a screening procedure, hair analysis is good. However, be aware that very healthy people use the hair as an end organ to deposit the toxic minerals in, and they don't have it in their body, they just have it in the hair or nails or desquamating skin. On the other hand, chronically ill acidotic people don't have the energetic systems to deposit the toxic minerals in the hair. So the hair can be low and the tissues can be burdened. I recommend the provocative urine test because it's not subject to those 2 additional methodologic impacts.
And how is that done?
I recommend that it be done with penicillamine, 500 milligrams, 4 times a day for 3 days. Collect a 24-hour urine starting on the 2nd morning. Call if you want the toxic provocative mineral, toxic provocative mineral test. Please call the lab SPL at 553-5472, and we'll be happy to send you out this, and we'll be happy to send you out also the immunotoxicity.
Is there any toxicity to the patient to do that? The penicillin?
Now, yeah, penicillamine, if you take it every day, which I think should never be done, has toxicity. If, however, you take the penicillamine for a brief period of time, 3 days, in autoimmune patients like multiple sclerosis patients who are symptomatic, who have a very high prevalence, sometimes up to 70% of MS cohorts will have mercury hypersensitivity, immunotoxicity, independent of their body burden. Even in the most at-risk group, penicillamine has been safely used for the diagnostic procedure without problems. Thanks. We have carried pregnant women to term. We have used it in the infirm. We have used it in children. When penicillamine is used properly, which means every other day or every third day, never, ever, every day. When penicillamine is used properly, it is an extremely low adverse effects, low toxicity material, and highly effective at getting into the body, into the brain, into the lipophilic tissues, into the deep cellular DNA histone sites where the toxic minerals can be, and mobilizing that. As long as you combine the penicillamine with the minerals, magnesium, zinc, and others, and the ascorbate, so that the body can help push and pull the toxic minerals out of the storage sites. And it may take months and months. We have seen people, Ralph Golan, Lisa Reamer, who collaborated with us on this, have seen people who the first toxic mineral might be mercury. And after 3 months, the mercury is gone. But now, lead and cadmium come up, and they weren't present before. Where'd they come from? From the cartilage, from the bone, from the large blood vessels that are now being recycled and synthesized in a healthier way, and you're mobilizing the deep tissue storage sites of the toxic minerals. So, hypersensitivity testing by immunotoxicity ELISA Act, provocative testing by D-penicillamine, or if you prefer DMPS or DMSA. Although at the recent GLACAM meeting, Rick Cohen and a number of us compared data, and the most predictive, lowest side effect, provocative material was the D-penicillamine.
I just want to comment because we talked about it 2 days ago.
Yes.
Downer, in his studies in the 80s, he has 7 major studies that he quotes that DMPS is far superior.
Yes, and
getting stuff out and safer. But
right now, where does that?
Yeah, no. But the point that I think everyone should get that this is foremost of before all other things. This is a legal way you can do it with your patients. You know that doesn't get you in trouble.
Well, the D-penicillamine is not an approved use of D-penicillamine. Penicillamine is approved only for Wilson's disease, but as a diagnostic procedure, you can legitimately use off-label anything. So for therapeutic purposes, you have to think about whether you want to follow with the D-penicillamine. For diagnostic purposes, it is absolutely okay. And how did this apparent discrepancy come up? The D-penicillamine binds the toxic mineral, particularly mercury, aluminum, and lead, so tightly that you don't detect it in your analytic machine, even though it is being mobilized from the body. So Dondera's data is correct. In the methods that were available at that time, DMSA would mobilize 20 to 50% more toxic mineral, particularly mercury, than would the D-penicillamine. But what was only found out in a publication 18 months ago was that the penicillamine binds so tightly, because it's an aminothiol, it forms a thiazolidine ring with the toxic mineral. It binds so tightly that it doesn't dissociate, and the mercury cold vapor methodology or ICP methodology for the lead and other toxic minerals understates how much D-penicillamine is pulling out by 20 to 50%.
So in the urine test, you say you're getting false negative.
You're getting a reduction. The amount you see in the average lab will be 20 to 50% less than you're actually mobilizing. Now, there are even newer methodologies that use sodium borohydride as a strong reducing substance to break the complex between the toxic mineral and the D-penicillamine. But the reason that I prefer the D-penicillamine is that tight bond is unlikely to dissociate in the kidneys, whereas DMSA and DMPS can re-equilibrate with the kidneys. Now you get around that problem if there's enough ascorbate, magnesium, and zinc to protect the kidneys, but just bear that in mind and balance it out. Many thanks.
This is our first introduction to Dr. Jaffe, and I'm sure by the look on your faces there that you're disappointed. I know that he's going to be associated with our group more in the future, and I certainly hope he gets his book back out, because much of what he talked about is in there, and you can mull it over and internalize it a little bit better than taking notes. We're going to take a 20-minute break, and then we'd like everybody to come back, because we still got two real good speakers.